Today we have the pleasure of hosting Dr. Theresa Soriano and Arthur Gianelli for a talk on delivery system reform incentive payment. Dr. Soriano is a board-certified general internist and palliative medicine physician and an associate professor of medicine, geriatrics, and palliative medicine at Icahn School of Medicine at Mount Sinai. She's a deputy CMO for vulnerable populations for the Mount Sinai Health Partners, the population health team within the Mount Sinai Health System. Before this role, she served as interim chief of the Division of General Internal Medicine, as well as the director of the Mount Sinai Visiting Doctors Program, the nation's largest academic home-based primary and palliative care program in which she continues to see patients. She has gained a national reputation in the field of home-based primary and palliative care clinical practice, quality, and leadership. This work culminated in her current role overseeing the development of innovative population health initiatives serving vulnerable populations with complex medical and social needs. Additionally, she is on the board of directors of the American Academy of Household Medicine and received the 2012 Hastings Center Cunniff-Dixon Physician Award for Excellence in Palliative Medicine, as well as the Department of Medicine Ruth Abramson Humanism in Medicine Award. Arthur Gianelli is president of Mount Sinai St. Luke's, part of the Mount Sinai Health System. Since 2006, he served as president and chief executive officer of New Health, a publicly run healthcare delivery system that provides high-quality care to Nassau County's most vulnerable populations and offers first-rate training to hundreds of medical professionals. He also served as the organization's executive vice president and chief operating officer. Prior to joining New Health, Mr. Gianelli held senior executive positions for 2 Long Island municipalities. He was deputy county executive for budget and finance for Nassau County and director of operations for the town of North Hempstead. He currently serves on the board of directors of the Long Island Association, Island Harvest, and Regional Policy Board 2 of the American Hospital Association. He also serves on the executive committees of Health First and America's Essential Hospitals. Please join me in welcoming Dr. Theresa Soriano and Arthur Gianelli.
Okay, these are the, good morning, first of all. My name is Arthur Gianelli. Theresa and I are going to be here to talk about DSRIP, the Delivery System Reform Incentive Payment Program, which is the major effort to fundamentally transform the delivery system in the Medicaid program in New York State. So first, just the slide on our disclosures. Neither of us have any financial disclosures that are relevant that we need to disclose at this time. The goals and objectives of our presentation are 3. First, we're going to describe the Delivery System Reform Incentive Payment Waiver Program here in New York State. Second, we're going to explain the factors motivating the shift from volume-based payments to value-based payments in the Medicaid program in New York. And then third, we're going to outline the Mount Sinai Performing Provider System's approach to DSRIP implementation and the implications for the day-to-day practice of clinicians throughout the Mount Sinai Health System. So I'm going to do the policy pieces. I'm not the physician in the room, probably the only non-physician in the room, so I'm going to do the policy piece and try to embed DSRIP in a larger context. So first of all, animating both the adoption of the Affordable Care Act and also waiver activity throughout the United States, something called the triple aim. And the triple aim is the notion that we need to achieve 3 things simultaneously in order to reform the American healthcare delivery system generally, and certainly the healthcare delivery system in the state of New York. The first is better care for individuals, and by that it's the typical IOM aims, right? Of safe, timely, effective, efficient, equitable, and patient-centered care for each and every patient that we see. We all strive to do that each and every day. The triple aim embeds that goal within its rubric. But the triple aim says to really reform the healthcare delivery system in the United States, you've got to go a couple steps further than that. So it's not only better care for the individual, it's better health of the population. And there, what the triple aim is saying is that clinicians and we as hospital administrators or leaders in hospital systems need to be thinking not just about the care of the patient in front of us, but what happens when that patient leaves our office? What happens when that patient leaves our emergency room? What happens when that patient leaves the 4 walls of our hospital? Where does that patient go? What happens to that patient? Are they compliant with their meds? Are they, do they have housing or transportation or food insecurity issues that have to be addressed? Are they being connected with primary care physicians? Once connected with primary care physicians, as Dr. Murphy was just pointing out to me, are they connected with other care, the other points of care delivery within the delivery system? It's a real question, and it's very important, and the concept breaks down the silos that we've historically been used to working with them. And the third is that we've got to do all of that, think about better care for the individual and better health for the population, while we're trying to lower costs, or at least lower the rate of growth in healthcare spending. As you all, I'm sure, know, the United States spends twice as much as any other industrialized nation in the world, whether you're looking at it at a GDP basis or a per capita basis, in how much it spends in healthcare. And it's an unsustainable growth rate in the United States. The cost curve has to be bent. The question is how, all right? You can bend it simply by cutting the reimbursement to providers. We've all lived that. We continue to live that. But that's not ultimately the most effective way to reduce the burden, the cost burden on the United States. Rather, what we have to be thinking about is how do we take the money that's out there, because we're spending a lot of it. How do we take the money that's out there and allocate it more effectively and efficiently? How do we lower cost by improving the delivery system, by improving the care model that we utilize to be able to take care of the patients that we serve? You all know about the Affordable Care Act. I'm not going to spend a ton of time here. I just want to point out a couple of things to place proper context. The way I look at the Affordable Care Act, and when I teach classes on the Affordable Care Act, the way I try to frame it is the Affordable Care Act really tried to do two things, all right? It tried to reform the insurance market, particularly for individuals and small group purchasers, but it also created a hotbed of innovation. And what the Affordable Care Act implicitly said is that we don't know what's going to work to change the delivery system, so let's try a whole bunch of things. Let's try a number of different experiments and see what happens. Let's organize these experiments around trying to achieve the triple aim, right? By imputing on providers greater accountability, either through the Enhanced Pay for Performance program, through value-based purchasing, or through accountable care organizations, and see if that leads us towards the triple aim. See if that leads us towards better care for individuals, better health for populations, and lower cost through improvement. That framework of reform, that commitment to innovation, that effort to achieve the triple aim, has made its way through the Affordable Care Act into a number of different state-level efforts across the United States to try to reform the delivery system. So you're seeing some common themes emerge at the state level, which would typically be around the Medicaid program. Whether it's expanding managed care, exploiting delivery system reform opportunities under the Affordable Care Act, participating in something called the State Innovation Model, which is something that the state of New York is participating in, where the CMS is providing financial and technical support to states for the development, testing, and evaluation of state-led, multi-payer healthcare payment and service delivery models that will improve healthcare delivery system performance. In the state of New York, there's a real effort to move all of our payers towards value-based purchasing. I'm going to talk about that a little bit later on. And also to adopt something called the Advanced Primary Care Model. Many states are launching the Medicaid Innovator Accelerator Program, where funding is being made available to help states accelerate the development and testing of state-led payment and service delivery system innovations. And many states are participating in the Delivery System Reform Incentive Payment Program. So DSRIP, which is a horrible acronym, I would acknowledge, but nevertheless, it's another piece of this sort of evolving landscape around Medicaid. You know, what's interesting about Medicaid is that Medicaid historically, certainly in New York, wasn't seen as a payer on par with Medicare or with the commercial payers, in part because it under-reimbursed relative to cost, still does, and in part because it was just seen as a way of providing support for those who were less fortunate or less affluent in the state. But through DSRIP, certainly in the state of New York, and I would submit in other states as well, what's basically happening is that Medicaid is moving from being in the back seat of the car to really driving the car of payment innovation and delivery system reform. DSRIP comes out as something called a Section 1115 waiver. Section 1115 is Section 1115 of the Social Security Act, And it's language that gives very broad authority to the Centers for Medicare and Medicaid Innovation to say, you know what, we can work with states to try to figure out what are ways where we can expand coverage or change the delivery system to the betterment of the patient population that we serve. And if we are able to do it in a way that is ultimately neutral from a financial standpoint to the federal government. The Massachusetts experiment, the experiment in Massachusetts led by Governor Romney, where the forerunner to the Affordable Care Act was created, was essentially undertaken as a result of a waiver, all right, where the federal government basically said to Governor Romney, you either are going to figure out how to expand coverage or we're going to take your waiver funding away. And they came up again with the predicate to the Affordable Care Act. Right? It provides a states with an avenue to test new approaches in Medicaid that differ from federal program rules. It will allow for experimental pilot or demonstration projects that promote the objectives of Medicaid. And they've been used historically, waivers, to be able to expand coverage, to change benefit packages, or institute delivery system reforms. In the beginning, DSRIP was focused really on safety net facilities, principally public hospitals, certainly in the state of California. But DSRIP has actually expanded its reach, where it's including far more sweeping set of payment and delivery system efforts. And again, it's explicitly tied to the AAA. So here you can see on this slide just some of the states that thus far, and there will be more to come, have adopted some form of DSRIP initiative. California was the first, the Bridges to Reform waiver. Texas was really the forerunner to the New York model. But there's Massachusetts, New Jersey, and Kansas as well. As you can see, the California model only had public hospitals. The Texas and New York models have public hospitals, private hospitals, and non-hospital providers, whether you're talking about physicians or you're talking about community-based organizations or long-term care facilities, any number of organizations that touch the delivery system and touch our patients. A number of other states, including Florida, New Mexico, and Oregon, are operating initiatives that share elements of the DSRIP waivers, and Alabama, Illinois, and New Hampshire are in the process of negotiating with CMS. Some common features. There are basically 4 common features of all DSRIP programs, all right? First of all, it's by way of context, DSRIP is not a traditional grant program. A traditional grant program is one where there's a competitive request for applications. You submit an application, you're awarded, and you get funding for the services that you articulate that you're going to provide, and you can be audited later on whether you spent the money on what you committed to in the application. This is very different. This says you as a set of providers, and I'll talk about what that set looks like in a second, you as a set of providers need to go at risk for performance. You need to achieve certain milestones and metrics. If you do that, that's when funding comes. All right? And the reason why the program is set up this way is that the federal government was concerned that waiver funding historically had not achieved the objectives that were sought. So the concept here is we're going to put the providers more at risk. If you don't achieve your milestones and metrics, you will not get the funding for which you are eligible. Each waiver has infrastructure development metrics and milestones, system redesign metrics and milestones. These are process measures. But then there are also, each district is leading you towards, once the infrastructure is built, leading you towards achieving certain clinical outcomes and achieving certain outcomes for your population. Now, why does this matter in New York? Well, historically in New York, Medicaid programs spent more money than the California Medicaid program and the Texas Medicaid program combined. All right, it was an outlier historically, still is, in terms of how much money is spent in the Medicaid program. And that's a function, frankly, of the way historically the Medicaid program was set up, where 50 cents of every dollar of Medicaid spending came from the federal government, 25 cents of every dollar came from local governments, and 25 cents of every dollar came from the state government. So if you were an elected official in the state of New York, you could say to yourself, geez, if I spend $1 in the Medicaid program, I can leverage 3 other dollars of investment, 2 from the federal government, 1 from the counties. This is a good deal. So we in New York turned Medicaid into a verb. All right, you know, the elected officials in Albany used to say, let's Medicaid that program. All right, meaning that let's just take it, put it in a Medicaid program so we can leverage $3 of additional investment for every dollar that we at the state spend. Well, that's fine until the spending gets out of control, which is what happened in New York. And not only was it out of control, as you can see here, all right, but we didn't get value for what we were buying. All right, as you can see, we ranked 50th in the United States in terms of avoidable hospital use and cost. So we spent a ton of money, all right? We turned Medicaid into a verb. If you look it up in the dictionary, you know, you see that for the state of New York, but yet we ranked 50th for avoidable hospital use and cost. Percent home health patients with a hospital admission, 49th. Percent nursing home residents with a hospital admission, 34th. Hospital admissions for pediatric asthma, 35th. Medicare ambulatory sensitive condition admission, 40th. And Medicare hospital length of stay, 50th. We were doing great, all right? Now, when the current governor came in, the current governor said to office, he said, all right, let me take a different tact. The typical tact historically was that the governor would come out, would propose a budget. The budget would have dramatic cuts for the hospital industry and for the healthcare industry in general. The hospital industry in particular would run big ads from SEIU 1199 and would drive down the governor's approval ratings. The governor would relent and everything would get restored in the budget. This would be year after year after year after year. This governor tried something a little different. He said, you know what, let me make an attempt to work with the associations and with the representatives of not only the hospital industry, but let me work with the representatives of all of the stakeholders. And the reason we need to do this is because the costs are just getting out of control, and everyone knows that, including the hospital, the hospital sector. So let's see if we can come up with a set of reforms that can hopefully bend the cost curve. And what they were able to do here is just that. All right, for the first time certainly in recent history, cost curve started to bend in New York. The reason why this is important is because what the governor did and what the New York State Department of Health did is they said, all right, you know what? We want that delta. We want the funding difference between what we would have spent and what we did spend. We want to take those funds and we want to reinvest them via a waiver in building our delivery system. And the key point here is it's to build the delivery system so that it is a durable, sustainable model that will permit providers reasonably and responsibly to take risk in the management of the Medicaid patients. And that's what led to about 18 months of negotiations, but that's what ultimately led to the DSRIP program in New York. Now, what I think is critically important, all right, because sometimes folks, when they talk about DSRIP, they talk about DSRIP either in the abstract or they talk about it in isolation. All right, I think in this presentation, we want to do two things. Dr. Soriano is going to make this concrete, and I want to connect it to other developments that are occurring. Because the reality is that DSRIP, which is really a large pay-for-performance program, really if you think about it, it's a large pay-for-performance program, isn't in isolation. The key is to undertake the projects that are associated with DSRIP to be able to secure funding in order to be able to build the infrastructure that will allow you ultimately as providers to undertake population health and to be able to be successful in risk contracts with the payers, which is why the state of New York has connected DSRIP with what they call the Value-Based Purchasing Roadmap, which is a roadmap, which I'll talk about in a second, to get us to a point where the predominance of our payments are risk-based payments in the Medicaid space. And also they've done something, or at least they're proposing something that's really it's unique in the United States, and that is to try to create explicit Medicare alignment in terms of how providers are paid and in terms of the organizational structures that are permitted in each, accountable care organizations as an example. So DSRIP, as we said, stands for Delivery System Reform Incentive Payment Program. It's an effort between the New York State Department of Health and CMS to improve the health of the state's Medicaid and uninsured populations. All right, about $7.6 billion is going to be allocated towards the providers that are participating in DSRIP. And DSRIP provides incentives to healthcare providers to build infrastructure and programs to improve population health. There are far too many metrics. Dr. Soriano will talk a little bit about that. But the underlying bottom line metric is that the Medicaid program needs to reduce its avoidable or preventable hospitalizations by 25% by 2019. All right, for I should probably do this. The central organizing rubric for DSRIP is something called a performing provider system. Performing provider system is the entity responsible for creating or implementing the projects, the goals of which are the reform and transformation delivery system for Medicaid beneficiaries and the uninsured. Initially, the performing provider systems were essentially virtual organizations, virtually connecting all sorts of different providers with this common objective. Ultimately, the performing provider systems have formed limited liability companies, which is what we've done here at Mount Sinai. And from these performing provider systems, risk-bearing entities need to be created. And each PPS has a designated lead entity. Mount Sinai is a designated lead for the Mount Sinai PPS. For performing provider systems to receive payments, you must implement projects. The state was very prescriptive in how it handled this. There are 44 potential projects, and each PPS could choose between 5 and 11 projects. They can't be repetitive. So in other words, we couldn't just choose projects that would get us funding for things we were already doing. We needed to choose new projects. And the projects must be intensely detailed with specific quarter-by-quarter milestones and metrics against which we would be paid. There are 10 performing provider systems in downstate New York with 25 statewide. You can see the list here. One of them, the first one, is a IPA-led performing provider system, which is creating a number of different challenges. One of the IPAs that's in the Advocate PPS is the Corinthian IPA, yet through our Health First relationship, we actually take risk on Corinthian patients. So one of the challenges is going to be how this is all going to get sorted out as time progresses. $7.6 billion will be distributed to PPSs for achieving these metrics and milestones. When we do our budgeting and planning, we made certain assumptions about what we think is achievable and not achievable for the money we've been allocated. The Mount Sinai PPS has been allocated about $390 billion. $1 million, excuse me, billion would be great. $1 million? Billion would solve a lot of problems. $390 million. We're anticipating in the end we achieve $300 million. If we achieve more than that, that would be additional funding that we'll be able to invest. In the beginning, all right, most of the metrics are process metrics, all right, so they're more readily and easily achievable. As time progresses, all right, the DSRIP period is a 5-year period. As time progresses, more and more of the metrics and milestones become outcome-based and feed into avoidable hospitalizations. All the while, there are some population health metrics that we have to achieve as well. The goal through DSRIP is to really make the system transform the delivery system to be able to address and undertake population health, moving the system from volume to value-based purchasing, getting rid of the silos, decreasing fragmentation, making things more seamless across care settings. All right, we're trying to engage patients proactively and systematically, not just on a targeted basis. The education of our workforce needs to be increasingly oriented, and that's part of the effort here. The education and training of our workforce needs to be increasingly oriented towards population health. The HIT needs are broad and significant, whether it's connecting up with the regional health information organization, whether it's bolstering the regional health information organization that we work with, whether it's creating the health information exchange connectivity to allow for the real-time exchange of information between care settings and amongst care navigators, whether it's the analytics that we're going to need in order to be able to really assess how we're doing in terms of population health. All that infrastructure needs to be built. And Mount Sinai is actually using some of these funds to be able to build a broader population health infrastructure to help with that transformation. And there's an emphasis and a focus, a renewed emphasis on addressing the non-medical resource needs of patients that are inhibitors towards obtaining care. A couple of other quick points. As I noted, value-based, the DSRIP is explicitly being connected to value-based purchasing. All right, value-based purchasing is the notion, all right, that we're going to move from a fee-for-service dominated world where we are paid every time we do something, all right, where the risk is on the insurer, not on the provider, to some level of what's called value-based purchasing, either shared savings with only upside potential, shared savings with upside and upside potential but downside risk, or capitation, global budgets, total cost of care, level 1, level 2, level 3 value-based purchasing. All right, the system is going to be moving towards these goals, and it's going to be moving dramatically fast towards these goals. In fact, so fast that by 2019, it's not just the stated objective of the Department of Health. The Department of Health is committed to this in the terms and condition of the waiver, that 80 to 90% of the state's managed care payments are going to be level 1 value-based purchasing or higher, which means they're going to be, at minimum, shared savings with a quality component, upside potential, no downside risk. All right, that means basically 80 to 90% of payments in the Medicaid space are going to be the equivalent of what you would see in the Medicare shared savings program. All right, but not on an isolated basis for the predominance of the program itself. In Mount Sinai, what we're going to do, we have a number of risk-bearing entities that we've created. In fact, we're working through what's necessary to achieve clinical integration for our principal IPA. But in addition to that IPA, Mount Sinai is going to be looking to create an IPA that's going to be purely and solely in the Medicaid space. And it's going to be running in parallel to the performing provider system that we've created as part of the DSRIP waiver. And the idea is that, again, the money that we draw down by successfully achieving project milestones and metrics is going to be used to build the infrastructure for us to be able to do population health right and to be able to successfully take risk in the Medicaid space. Right now we have basically one risk contract. We have a total cost of care contract through Health First for about 120,000 Medicaid lives, but we do not make money on that in taking that risk. We do very well in our Medicare risk. We do not do as well in Medicaid risk. There's a whole host of reasons why that's the case. I think adverse selection is a piece of it. I think very high-cost prescription drugs, particularly for the HIV population and the Hep C population, are also big contributors. But also because Mount Sinai, because of its reputation, it tends to attract the sickest population, and also it tends to attract a significant behavioral health population. So we're going to have to deal with the adverse selection question, but even beyond that, we need to have the infrastructure to allow us to be able to optimally manage these patients. And that's what the IPA is going to look to do. We're going to be looking, frankly, to stand up the IPA and then get it operating and actually negotiating with payers in 2016. The last point, if you remember those 3 prongs, right? The creation of the delivery system reform incentive payment program, shift from volume to value, and the value-based purchasing roadmap. The third prong is that the state of New York is actually proposing to the federal government. The federal government hasn't accepted this, but the state of New York is proposing to the federal government that the New York State providers and managed care organizations include Medicaid beneficiaries in CMS payment models, and allowing New York State providers to include Medicare fee-for-service patients in the value-based purchasing arrangements. Basically, what the state's asking is to take the Medicaid and Medicare delivery system structure and payment structure and merge them together. No other state's done that, and they've actually requested that Montefiore, the Montefiore Health System, be the first ACO in the country to assume full financial risk and population health responsibility for both its Medicaid and Medicare population under one rubric. These are big deals. All right, and certainly with the lead of Dr. Davis, who has made it very clear that Sinai needs to make this shift, this is the direction that we need to go. What all of this means is a very, very complex time now for the Mount Sinai Health System, specific in hospitals generally, because you have to balance out, all right, the changes in the delivery system and the changes in the payment system. All right, if you make the move too fast in how you change the delivery system, and your payment system, your payments haven't caught up, you end up reducing hospital demand prematurely, and then you reduce your revenue, and that ends up hurting your bottom line. On the other hand, if you don't make the investments in population health and the investments in doing things like reducing readmissions and reducing avoidable hospitalizations and reducing overall utilization, what you end up doing is not being prepared when this value-based purchasing roadmap is fully implemented, and by 2019 it's going to be fully implemented. So the real challenge for this system in general, for all of the hospitals in particular, and certainly you as providers, is how do we affect that balance? How do we affect that balance? It's very, very, very complex. I've been dealing with this on a day-to-day basis in cardiology and in other disciplines as well, where how far do you push the needle, all right, towards the reduction in inpatient hospitalization, and when do you push that needle, and how do you calibrate that to when the payment system changes? Because as you can see, under the emerging model, when you move down the grid here towards capitation, hospitals which used to be revenue generators, which used to be thought of, this is the way you make your money, increasingly become, to the extent that you're capitated, you're at total cost of care, increasingly become cost centers. The whole model gets flipped on its head. And that's the fundamental challenge that we're going to be facing over the next several years. The idea is, through DSRIP, is to try to use the DSRIP money to fill in the gap, all right, of funding while these changes are taking place. And again, leverage the funding to be able to build the infrastructure. And that's the infrastructure that Dr. Soriano is going to talk about right now, laying out for you how the Mount Sinai PPS is organized and the projects that we're undertaking and what that's going to mean for on-the-ground clinical transformation. Thank you.
Good morning. Thanks, Art. Nice to be back in the department again. So everything Art said was super clear, right? Got it? I can't say I will be all that much more concrete, but I will try my best. I have to say, as a clinician getting into this world, I've learned a lot of acronyms, a lot of policy talk, and I see now why it's so difficult, when we're in our practices saying, why can't we just do this? And the financial motivations, the payer motivations are just very nonsensical in a clinical world. So DSRIP is very exciting because it's, for the first time, at least at the state level, allowing the clinicians and what we do every day and what we see works in small scale and what we see works out in the community might actually be supported through DSRIP and later on. So I'll talk about the Mount Sinai Performing Provider System and how we're about to implement this here. As Art mentioned, our goal is to improve and create a sustainable, seamless, population health-driven infrastructure which improves quality, reduces costs, and improves the patient experience. Our Mount Sinai PPS actually is one of the largest in the state. We have 275 parent organizations, over 4,000 unique programs, facilities, sites, pharmacies, community-based organizations, including legal aid, Meals on Wheels, so not the traditional providers we're used to thinking about. Almost 5,000 primary care and specialty physicians, the largest chunk of which are here at Mount Sinai Health System, which is not a surprise, but not by much. We have many, many community-based providers and federally qualified health centers in our partnership, and over 370,000 patients, we think, throughout Manhattan, Brooklyn, and Queens. The state assigned us 3 counties in New York, and these are the 3. So we're not in the Bronx, we're not in Staten Island. However, it is not inconceivable that patients that we serve might live there. It's all based on Medicaid data, which is, we have realized, is very flawed. I want to make the distinction between the Project Management Office of DSRIP, the DSRIP PPS, and I'll talk a little bit more about this, and the Mount Sinai Health Partners. The PMO, or the Project Management Office, is for people who have gotten grants and operate interventions that run under grants. The PMO is sort of a very large version of that. program coordinators, people who are making sure that you're dotting your I's and crossing your T's, submitting the right things to the state or the funder, keeping everyone in line, making sure that the work done is the work we said we were going to do. In this case, submitting quarterly reports, doing the financial management, the project management, and ensuring that all of the requirements, including compliance metrics, are being met. Mount Sinai Health Partners, which is the group I now work in, it's also called the Population Health Team or the MSO, and you'll learn more about that soon, really is sort of the backup system for the system, which is helping to provide the clinical, the IT, the data analytics support, contracting, the payer, meaning insurance plans, and the provider relations that will help support all of the DSRIP projects actually happening, not just within our system, but outside the system to all of those partners I just mentioned. And as time goes on, if the individual partners feel that they would like clinical support, they want to adopt one of our models that we are doing here, they want some IT help, they want help connecting because they don't have their own infrastructure, then Mount Sinai Health Partners will be able to provide that. So I'll use the pointer here. This is the Mount Sinai PPS governance structure, and this is the PMO, Project Management Office. So they are making sure that the nuts and bolts of everything are working. It's, like I said, not just the clinical stuff that I will be talking about, but everything Art was mentioning, the workforce training and what workforce should be doing what new work, what old workforce needs to be doing new work, and how do we retrain people who are traditionally used to fee-for-service medicine or inpatient care into what Medicaid has also said needs to be moved out of the hospital or out of the institutional setting. The Finance Committee has a very big job trying to figure out how the funds from DSRIP will be flowing to our system as well as all the partners, how to allocate these funds that, while $380 million sounds like a lot, for this kind of project over 5 years, over 300 partners is not that much. The IT Committee standing up all of this infrastructure to connect our partners and, of course, compliance because it's New York State. But there are a lot of issues with different providers sharing information, sharing claims, sharing a lot of their confidentiality issues that we really need to be very, very vigilant about making sure we're compliant in how we interact with each other. Cutting across all of these different committees, and these project work groups I will go into more detail about, we have larger cross-cutting cross-functional work groups, care coordination, stakeholder engagement, and patient-centered medical home, which the state has really adopted as the model for our primary care practices. And like I said, the clinical committee and all of these projects, as well as the cross-functional work groups, again, as a clinician, is really what the meat of the sandwich is. The pieces of bread are very important. You don't have a sandwich without the bread, but you can't have the policy reform, you can't have the payer contracts and be successful at them without the clinical programs being strong and successful themselves. So our PPS chose to do 10 projects, and that was based on a community needs assessment that was done in 2004. A lot of them, and as I go into them, you'll see are very interconnected. The way our PPS structured the co-leads of the projects were really based on experience working in the community as well as experience in the core types of activities that each project required. You'll see a lot of familiar faces. A lot of these are very primary care centric, hence a lot of primary care colleagues who are co-leading this. We also have co-leads who are from the other sites, St. Luke's and BI, as well as community-based partners, a lot of whom have tons of experience with the other non-medical needs that need to be carried out through these projects. And I just want to say this was all done purely on a volunteer basis, and the hours and hours of work since, I think, April 2014 should not go unnoticed by your division chiefs. I'll send this around later. So Project 2AI is the project. It's really a misnomer to call them projects because they are huge, huge efforts. The one project really involves the changing of multiple systems to make it work. And this is, probably the pinnacle of that. 2AI is the creation of an integrated delivery system focused on evidence-based medicine and population health management. And the main tenets of this is really increasing and creating access to medical care and community support services. So Mount Sinai does a fairly good job creating access to medical care, and an okay job making sure that we are referring to the right community supports, but we can definitely do better, and I think in practice we know we can do better. It's making sure that we have the resources and systems to be able to do that. Engaging and educating both the patients and as well as the providers. Many of us have never heard of this. This is the first time you're actually hearing about DSRIP. And also knowing about what the value-based payment motivation is through this that Art was telling us about, that really is what is going to make this work. We've all tried to create great models under grant funding, under demos that don't survive because they don't work in a fee-for-service world. Sharing health information across sites and across systems, using analytics to help guide our decision-making and to know how large to make a program from the start, which is always a challenge, and also, again, not our job, but establishing these value-based payment arrangements. Every provider, every partner is part of this project. This is definitely not my thing, but this is just an illustration of what our IT colleagues are being tasked with, creating, as the lead PPS, creating an infrastructure by which we are able to exchange health information internally across our different sites, which we know is still a challenge, having the proper data analytics, using a universal medical record number called an EMPI, being able to keep track of all of our partners within the PPS, how to keep track of the trainings, making sure we're secure in how we message and send messages and information. Again, having a working care coordination platform that may also feed into our EMR so that the clinicians can see the information they need without seeing everything else, and vice versa, where care managers don't necessarily need to see every note that was written by a physician. The use of telemedicine when appropriate. There's a lot of evidence out there that telemedicine works, but with whom does it work best? And in the Medicaid population, what's the best way to use this? And having all of that not just work within our system, but through the PPS with all of our community providers, using the statewide regional health information organizations work through our other boroughs. And then hopefully with the state, using their shiny system to feed information at the state level into our system. So that's a whole grand rounds in itself, and we know though that this is so important to be able to make the clinical programs work. Care transitions intervention to reduce 30-day readmissions for chronic health conditions. I'm not going to go into the bottom bullet, but I just want to show you the scope of the number of patients that need to be reported on by the state. That's the game of DSRIP, where one of our process measures is that we have engaged 25,000 Medicaid patients for this particular project, in that they all have a care transition plan within their discharge summary. So a discharge summary isn't enough, but a plan showing their care transitions and how they will be followed up, along with documentation of that developed before discharge. So that means utilizing a lot of our care transitions interventions, allowing outside providers into our hospital systems. Again, no small task. And then the ability to use other programs outside of the hospital to help reduce our readmission rates. For patients who are leaving the hospital or a nursing home or another institution into home care, so into a VNS type of arrangement at home, this project tries to use the nursing home-based Interact module, which is really clinicians understanding warning signs, or non-clinicians understanding warning signs, and being able to communicate that back to the provider who can help them make a decision. Sort of like our sepsis protocols, when things pop up on the EMR, or if you see a trend in vital signs, before things are actually bad, you talk to the right person who can help you deter that ER visit. This is supposed to engage 20,000 Medicaid patients in a given year. The development of a community-based health navigation system really long-term means that we need to build a system-wide clinical command center. We have learned over the course of DSRIP planning that we have many call centers, many physician access service inputs, many ways by which the outside can access the inside, and all of those different ways lead you in many different directions into our system. So being able to have one access point that will bring a patient or a provider or a caregiver who's not in our system, or even who is, to the right place is the long-term strategy. In the short-term strategy, because this is a Medicaid project, we are going to be leveraging our hospital ambulatory care call center as well as our small care coordination center, which is part of the Mount Sinai Health Partners, to begin doing this for DSRIP. And we just got our 1-800 number. But we hope that, again, this is where, as Art said, this is not happening in isolation. There's a larger system-wide effort to create this larger call center, but we hope to bring these together over the 5 years and then some. And again, this is really a community-based project, and while it will leverage our in-house health homes work, our care managers that are in our practices, in our institutes, this is really going to force us to work outside of our walls. And in a way, that's good. We tend to, as an insular system, want to build things ourselves, but we have so many partners out in the community who do a wonderful job and have been doing this for decades, engaging patients in the community, helping them navigate their own neighborhoods. And there's no reason for us to build that ourselves with our relatively thin resources. We should be partnering better with the community. Project 3AI is the integration of primary care and behavioral health in multiple different settings. This is leveraging a hospital medical home New York State demonstration grant that happened at IMA as well as IFH, where we put behavioral health services, mainly run by social workers, and a depression care program in our IMA. There are plans to do this in our psychiatry, in our pediatrics associates this coming year, and also vice versa, which you see there are 3 different models, putting primary care physicians and providers in our behavioral health sites, and this is happening at St. Luke's. This is obviously being done in tight collaboration with Sabina Lim and the psychiatry department. 3A3 is part of the behavioral health for patients who need very close behavioral health medication compliance. We are trying to tightly link this with in medication compliance programs for patients with chronic medical conditions. People who are on long-term behavioral health meds tend to also have chronic metabolic diseases. So we are trying to tie that together with these other projects coming up. Are you following? This is a lot to keep track of, so you should not feel bad. I'm constantly lost. 3BI is evidence-based management and prevention of cardiovascular conditions. You see the numbers going up. Again, I'm not going over them specifically, but these are huge, huge endeavors, not our 500 patient pilots that we tend to run under grants. This is utilizing the Million Hearts campaign, which are set protocols and standardized guidelines, mostly to be done in the primary care setting, by which we better manage, better screen and identify patients with cardiovascular conditions like hyperlipidemia, hypertension, and manage them earlier on, knowing when to refer to specialists, how often they should be seen by specialists, and really, again, utilizing care pathways that are being developed now in our cardiology and primary care settings, and trying to scale that across our PPS. And again, trying to tie this into some of the medication adherence projects that is really more behavioral health, but these are the same patients. 3CI utilizes our Diabetes Institute, our Cardiovascular Alliance, our DCDEs, our demo that's going on at GMA and IMA, affecting high-risk and affected diabetic adult population. Again, we are working in collaboration already in a number of pilots, and this will just serve to expand and provide a little bit more support for it. 4B2 really is trying to leverage, as Art was mentioning, we already run some risk and participate in a lot of pay-for-performance programs. And people groan because when you're an IMA or you're in another primary care setting like Coffee Geriatrics, you get your screen, and everyone who is not in a primary care practice might see this too, the big, long BPA list of things you need to do for your patient. That actually, indirectly or directly, equals pay-for-performance dollars for plans like Health First or other plans that we will soon be in contracts with. So for the house staff and the attendings out there, I think the attendings have gotten a lot more of this information. It is good care to screen for diabetes and to do these preventative screenings. It's hard to do with our patient population. With the support, we're still trying to get into the clinical settings, but it is one of the projects that we chose because we're already doing a lot of work in it. We knew we could leverage the Epic and IT processes we have and hopefully make them more user-friendly and also have more staff trained to be able to do this for us and with us. And these are just some of the screenings: breast cancer, cervical cancer screenings, colorectal cancer, hepatitis C. You'll see here HIV. We have one of the largest HIV populations in the state, if not in the country, and the city actually together decided to, all the city PPSs agreed to participate in this project together. So they're a lot more ahead of us in terms of really putting their resources together, acting as a coalition, and using the collective resources of all the PPSs to increase rates of screening, rates of retention in care, and rates of engagement in other kinds of care that are non-HIV related. You may have noticed that there are definite overlaps and similarities between the projects, and that's actually how our PPS has started implementing the projects, where the Integrated Delivery System Development Project is its own thing, but it encompasses all the other projects. Improving care for behavioral health populations. We are encouraging our partners and our site to participate in both, because each project actually, in the way the dollars are allocated, each project can earn you a certain amount of dollars. So for a site to be engaging in one project when there's another one that's so related that might need just an incremental amount of work, we're trying to maximize the funding each site can get by encouraging them and helping them do the similar projects, which will also help their other processes. Chronic disease management and prevention, we put that together. There was some concern about putting HIV care into that, but we believe HIV is a chronic disease and a lot of their comorbidities are actually tied to these other conditions. And successful transitions from hospital to community or home care. And that's closely tied with these projects, obviously, with community-based health navigation and the eventual call or command center really being at the heart of making all of this work. So how are we actually going to do this? This is extremely overwhelming from a clinical standpoint, and we know that this is, again, the meat of the sandwich. If these are not successful, we cannot draw down the dollars to earn these incentives that Art was telling us about, that we need to reinvest in all of these programs, as well as all the other infrastructure that needs to be built. And the two things I really want to highlight here are the education and engagement of all the stakeholders, our providers, our patients, about the goals of DSRIP, the opportunities here for us as clinicians, as well as for patients. This is the Medicaid population. They are the ones that we know fall through the cracks first and farthest. And this is specifically meant to improve the care for them. For the providers, this is not, we've heard it before, more metrics, more this, more that. We're trying to be very mindful of not adding on to the workload that we already have, but trying to use what's already out there, trying to streamline it, make it make sense for this program. So making the work we do fit the DSRIP metrics and milestones so that we can, for lack of a better term, collect on that and gain more resources to improve how we work. We talked a little bit about aligning incentives, and that includes working with our departments and working eventually with the payers to have compensation and incentives align not so much with just volume and how many patients you can see in a given session, but and for some divisions, this is happening a little bit more aggressively, where there are going to be links to your outcomes, the value you are providing in terms of care for your patients. And right now, that's linked to quality metrics and other sort of process metrics, but it's a start, and it helps you sort of know that things are moving in the right direction in terms of patient care. And again, collaboration is key. We have 275 providers. We cannot do this ourselves. I think we've seen what happens when we try to build our own things and not really look outside our walls. 90% of care for a patient happens outside of hospitals, so we need to really keep that in mind as we try to build these systems. This is just a slide showing all the different ways we're trying to communicate, both within and without. There is a web page and a newsletter, and I'll show you how you can access that. Something we're not living in a bubble here, and we know how hard this is going to be. I think more than anyone, we realize that this will likely be very difficult to pull off in 5 years. Mainly because there are so many other things going on, and the 5-year pace is, in truth, very unrealistic. But we're going to do our best. The funding is not the funding we thought it was going to be, and we know that there's just a lot of program complexity and difficulty in trying to address social determinants of health in such a diverse population, including confidentiality issues for emancipated minors, substance abuse patients, behavioral health, et cetera. The state has not delivered its part in creating the IT infrastructure, so we need to work with that. And also, I think stuff we're hearing, the sort of inconsistent evidence about these alternate payment models like ACOs, like PCMHs, how well do they really do? I think the jury's still out there, but we see on the ground how important changing the way we do things needs to be. Dr. Davis and our media department say we are all in, and we really are. This is how healthcare needs to happen, especially in the Department of Medicine, where our jobs of managing chronic conditions, managing difficult and complex patients, we know that fee-for-service doesn't work. So we really have to try to embody this thought. And for people who are involved, going to be involved, I mentioned this is very primary care oriented right now, but we will be pulling in the specialties very quickly, including the emergency department, surgery, the interventionalists. This is something that involves everybody, so don't be surprised if we come knocking at your door. Thank you. Sorry we went over. There's a lot to go over.